First of all, some facts about diabetes disease. We know about this leading cause of chronic kidney disease and end-stage renal disease. And we understand nowadays that if you want to prevent the burden of chronic kidney disease in end-stage kidney disease, we have to understand this diabetic kidney disease more in detail. So diabetic kidney disease has different phases and it's very complex, and also in the field of pathohistology. So from clinical point of view, the proteinuria is a marker of disease severity and is also a marker of increased cardiovascular risk. So proteinuria is also considered to play a central role in this disease progression, of course. This is a review of by Jefferson and colleagues described the pathohistological mechanism at the cellular level and try to explain us why the patients with diabetes kidney disease develop proteinuria. Also, these characteristic pathological changes in the diabetes kidney disease include thickening of glomerular basement membrane and the mesangial expansion. These changes actually per se do not easily answer the question why actually the patient developed proteinuria. So recent advances has done in the podocyte field and the glomerular endothelial cell biology. We learn in the school that the kidneys are typically enlarged and the hypertrophy of tubular cells and glomerulomegaly is present. So glomerular basement membrane thickening is usually the first manifestation and is due to the deposition of collagen 4. Slide 5, please. This is produced actually this collagen from the podocyte. The mesangial expansion is also results of increased extracellular matrix protein and mesangial cells hypertrophy. So we are also facing in this diabetes kidney disease with the pictures like mesangiolisis, and we find these Kimmel-Still-Wilson nodules and some microaneurysm. So moreover, we now know that actually the exact mechanism of proteinuria of this patient is still not fully known, but we know that microalburminuria should indicate incipient and proteinuria overt diabetic nephropathy. But this has been recently challenged by studies showing that patients without proteinuria may also develop the kidney disease. So we now know this non-proteinuric phenotype of renal disease. So in daily clinical practice, we have some problems to deal with this topic. First, usually diabetic patients do not undergo the renal biopsy unless the case of the patient is not clear enough or the course of the case is not going into the supposed direction. Therefore, the renal histology information are really limited and little evidence is available regarding the morphological changes. About clinical to histological correlation, this is a special field which we have to address because in the early stages, we don't know much about these correlations with the clinic and histological changes regarding the outfit of Normo-Alburminuria and microalburminuria. However, for the histological background, we can use the classification. Please, next slide. And this classification is something what we in the daily clinical practice observe and realize when we send some samples for the biopsy, some samples of our patient. So we are aware with the specific changes the colleagues pathologists describe us. So you can move on. The next slide. During the past years, the researcher tried to understand this relationship between diabetic disease and onset of proteinuria. So they simply concluded that in a patient with diabetes, no change in size selectivity was found, and this is of course the meaning of this radius of pores and special spread distribution of small pores or magnitude of the large pores. And there are some suspected changes in the charge barrier within glomerular basement membrane. This is actually something what they found previously. And the studies of Anderson, Höstler, Brenner, they show that the chronic elevation in intraglomerular pressure leads to progressive glomerular injury. And this progress also proteinuria. and to further damaging the filtration barrier. So you can move on, please. The next slide. Yes. Furthermore, the authors connect the proteinuria with endothelial injury. So they stated that systemic endothelial dysfunction is present in diabetics. We are familiar with this Steno hypothesis. Albuminuria is a kidney manifestation of systemic endothelial dysfunction. And of course, it's a marker of vascular damage, allowing the leakage of several molecules through the vascular wall. Also, defects in the glomeruloendothelial glycocalyx was observed and was found. And also this increased production of vascular endothelial growth factor, which actually increased formation of fenestra in endothelial cells, which all leading to increased permeability. Next slide, please. Thank you. Authors connected increased permeability of the glomerular basement membrane also with the loss of heparan sulfate proteoglycans, and with this thickening of glomerular basement membrane due to the accumulation of extracellular matrix proteins. Next slide, please. Recently, more is also known about the podocyte-related damage. So reduced number of podocytes with the process like apoptosis, podocyte detachment, and the inability to proliferate from the podocyte leads to proteinuria due to the overall loss of negative charge I discussed before, and due to this disruption of the normal architecture of the podocyte monolayer. And also changes in this slit diagrams, yes, was found. So reduce expression of nephrin molecule inside, food processing widening and effacement, and cytoskeletal changes inside the podocytes per se. Next slide, please. In this case of the electronic, in this case of the problem, the electronic microscopy could be a very elegant tool. And here on this slide, you can see what I discussed before. So there's a marked mesangium expansion. There's a thickening of membrane and segmented effacement of the podocytes cells. Next slide, please. To point out the role of mesangial cell, we should be aware of some facts. So mesangial cells expansion and this formation of already mentioned Kymel-Wilson nodules and microaneurysms could help us to understand the fall in the estimated GFR in diabetes patients. Due to these structural changes in the mesangium, secondary podocyte injury also can be the defect, and glomerular hyperfiltration occur, and of course all together leads to this proteinuria we are discussing today. Next slide, please. These are some pictures of this already mentioned changes, nodular sclerosis, different colorization, very nice pictures from the literature. Next slide, please. Regarding the proteinuria and tubulointerstitial injury, we have to say that there's often substantial tubulointerstitial changes seen on renal biopsy in diabetic. And tubulointerstitial scarring is perhaps the best, okay, not the best, but serious predictor of renal survival in both diabetic and non-diabetic disease. So there's also direct correlation between the degree of tubulointerstitial scarring and the extent of albuminuria due to the interruption of protein reabsorption, especially in this proximal tubule area. Next slide, please. The picture, just to summarize what I said before, this tubular atrophy and interstitial fibrosis, which is seen very often. Next slide, please. So to conclude, the renal biopsy, unfortunately, is not the standard of care in diabetic patients in daily clinical practice. So to understand diabetic nephropathy, histological evaluation is on the other side crucial. Clinical pathological association in diabetic nephropathy is deficient. So the presence of severe lesions like we discussed before, nodular sclerosis, tubular atrophy, fibrosis, inflammation also are associated with proteinuria. But less is known about the same association in patients with normal-microalbuminuria or microalbuminuria. So there's the fact that mostly the studies published before, available studies, are low numbers regarding the number of glomerulus and other structures. So 20, 30 glomerulus per person. So that's why the careful further discussion, the research is needed. Next slide. So, and to finish, please allow me to direct you to recently published already paper in Kidney International Reports from Esteban Purina and colleagues, the Diabetes Working Group of ERTI. So this was a renal histology in patients with type 2 diabetes with different stages of proteinuria with normal and reduced renal function. And so what I found, actually, this was a multi-center study that includes 15 centers from 6 countries in Europe. And this is a part of the European Nephrectomy Biobank and BIBA project. So the study was designed to analyze unaffected tissue of nephrectomy specimen. And so this procedure ensures us the sufficient material for further analysis. And 92% patients with diabetes were included. And the mean number of glomeruli per patient was about 170. So very, very, very high regarding the previous study. And so also there were samples full of small arteries and arterioles. Next slide, please. And here are the major findings of the study. So the authors concluded that there's a lack of correspondence between the renal histology, the classes of diabetic nephropathy, and different stages of proteinuria in patients with diabetes. So advanced glomerular, tubular, and interstitial lesions were observed in patients with normal-albuminuria. And on the other hand, also mild changes were found of the same structures in the subject with high proteinuria. Mild glomerular changes was concomitant to severe tubular and interstitial lesion also. But the most important, vascular lesions like arterial hyalinosis and fibrointimal thickening were extremely frequent and distributed among the classes of diabetic nephropathy of different stages of proteinuria. So different conclusions can be found in this manuscript, but most importantly, most patients had really, really, really vascular damage. So this is something what indicates us that this damage is a major role. The major role could play the ischemic damage in this population of patients. Next slide, please. These are some very beautiful pictures done from colleagues on the pathology department, and you can see what we discussed before, these vascular lesions very clearly, like arterial hyalinosis, fibrointimal thickening, and with the different type of patients regarding the level of albuminuria. The next slide, please. And with this slide, I will really finish, and I would like to excuse myself again for this horrible technical problems, but I truly believe that you got at least information from my side which could be helpful for our future work and future research. Thank you very much for your attention.
Oh, thank you, Sebastjan. Can you hear me? Ah, perfect. It was wonderful. It was a wonderful talk. Can we see your face? Again?
Yes.
Okay, put the camera or something like that.
Like that.
Oh, great. Thank you very much. We are sorry for the technical problems, but these things happen. We think that everything is solved in this modern world, but these things happen, don't worry. Well, there are questions from the audience? Much from the chat, do you have something? Enrique will ask something.
Sebastjan, very nice presentation and very stimulating and the vascular lesions. My question is in this direction, in this line. This information is very important for the clinicians because the vascular damage, because always we are looking only the glomerulus and never look to the vascular or the interstitial fibrosis. Would you consider that this discovery of vascular lesion is possible to change the treatment of our patient with diabetes and focus on the vascular lesion in all, not only in the glomerulus? What are your opinion about this?
Thank you very much for your comment and nice words. Of course, I strongly believe that this kind of results will change a little bit our daily practice in a way that we will try to do more in a direction to find and to cover atherosclerotic risk factor more aggressively, because we know that with this kind of acting, we will at least diminish the effect of aggressive accelerated atherosclerosis in this population. So my answer simple is yes. I strongly believe that these lesions we showed will encourage us to more carefully check the patients already with just a minor or no albuminuria.